Good evening, ladies and gentlemen, and to everyone who's watching us live. My name is Ruben Lobo, and I invite you to the last session. In fact, the best session on the fifth day of the biggest implantology event of 2020. Ladies and gentlemen, I hope you all have been doing well and you're keeping safe. Ladies and gentlemen, it's the last session of the fifth day, but believe me, it's going to be the best session, certainly because of the best speaker that we have. We are so very blessed to have with us Dr. Souheil Hussaini, who's going to talk on the much needed topic of 2020. This topic has been into controversy. This topic has been into a lot of doubts, worries, and difficulties. But believe me, at the end of the presentation, I hope and I'm sure that all your doubts with regards to you practicing implant dentistry in 2020 will be cleared. Ladies and gentlemen, we have with us a very special speaker amongst us, Dr. Souheil Hussaini. A short introduction about a speaker. He completed his post-graduation in prosthodontics, TMD, and implant dentistry concurrently with a Master of Science degree in oral biology from the University of Medicine and Dentistry, New Jersey Dental School, USA. His undergraduate degree and PhD was from Annamalai University, RM Dental College and Hospital, India. He is currently holding a part-time faculty position as an adjunct faculty at the Rutgers Dental School, USA. His master's research and PhD was in the field of dental implants. His private dental office is based in Dubai, where he performs implant surgeries and prosthetic treatments. He is the founder of Implant Dentistry Study Consortium, the IDSC as it's colloquially called, the first ever ADA approved dental implant continuing education course in the Gulf and the Middle East, which is also an affiliate of the Society of International Congress of Oral Implantologists, the ICOI, as well as the University of Toronto. He is the chairman of the scientific committee Implant Dentistry Consensus, UAE. Since the year 1997, his experience is exclusive in implant dentistry with most of the implant systems. He's presented lectures at the Harvard University, at the Pennsylvania Penn University, at the Hunan University in China, as well as the University of Toronto. He's organized several social, economic activities and dental camps in various parts of the globe. Ladies and gentlemen, presenting to you, Dr. Souheil Hussaini live.
Hi, everyone. I wish I could see your faces, but the best I can do is just to imagine that I'm talking to a group of interested people in front of me. The topic of practicing implant dentistry, if we look at it as how we can understand this concept, why it doesn't fit in a prosthodontic postgraduate studies or a periodontic or oral surgery or any other specialty, is because it is different. It's multifactorial. So for me to be able to understand implant dentistry, I thought I should look into different systems which are governing our society or our life. If we look at how our gene regulation works, as you can see on the screen, it's a very complex methodology. How does it correlate or corresponds to each other? If we look at, say, for example, different examples, how our brain functions, is also very complex. How the economy and the market actually is running in the world. It needs an understanding of so many resources and so many information you need to have to be able to understand the concept of these methodologies. How does the birds know, for example, to travel for thousands and thousands of miles in summer and come back in the winter? Or how do these ants communicate? What are the systems that make all these understandings to function in a harmony? So the simplest one I found, which we all understand, and it's applicable to this concept of implant dentistry, was the ecosystem. Or in our, when we were in 3rd grade or 4th grade, we study about food chain or food web, where there are, it's a pyramid in shape, and there are different importance of all of the elements are important, but some of them stand on the higher part of the chain and some of them stand in the lower part of the chain. If you look at it superficially, basically there are humans who are using the animal kingdom and the vegetable kingdom and the mineral kingdom to be able to survive, and so as the animal kingdom and the vegetable kingdom. On the surface, everybody is getting along, but if you want to go theoretically and look at the exact, how does it work? How do the plants and worms and the algae and the seals, how do they correspond to each other? Actually, it's sophisticated. Same thing with implant dentistry. We'll see both ways. How can it be so simple? And if you want to get deep into it, how it can, you can still, as deeper as you go, as deeper it gets. So let us look at ecosystem and take that as a culture for implant dentistry. Since we all know that implant dentistry is inevitable, there's no one today who can say that I do not require to know about implant dentistry. With that theme, since we all need it, let us look into it as something we really need to have or to know or to practice. Now, this pyramid is the closest structure I could get to for me to be able to understand implant dentistry and explain it to everybody else. We have a center of the pyramid, we have the top part, and we have the base. So the center of the pyramid is where we have to understand what's diagnosis, how do you diagnose a case, how do you do the surgery. Now, when I say surgery, I don't mean only placing implants. I'm talking about all the possible soft tissue related, hard tissue related, augmentation related, external sinus lift, block grafting, PRF, PGR, anything you think of which is surgically related comes under surgery. Then it comes the uncovering. Now, today with the world of digital dentistry, uncovery has definitely another meaning. And to understand, the deeper you go into it, soft tissue grafting plays a big role in this stage. And the impression, again, today many of us are only purely practicing digital impression techniques. Some of us are mixing both the manual as well as the digital. Then comes the restoration. We have so many types of restoration today. As you know, we have the multi-unit abutments, we have the dynamic abutments, we have the screw retained, we have the zirconium material, we have so many technologies in the restoration. And the most important part is the maintenance, where patients basically should not be left alone for many years, because that's where things can go wrong. And our statistics have shown we have around 50% peri-implantitis in our cases. So this is, we're going to go into detail of the center of this pyramid. The top part has to do with you setting up a protocol or setting up a methodology where you can explain to your patient the basics of implantology. For example, let's look at general info. The patient needs to know what is implant dentistry. And you should have enough, in a simple layman's term, you should have enough information in the language that you and the patient is comfortable to be able to communicate a basic general information on implant dentistry, which is simple, yet it's informative. Most frequently asked questions, it can be written in any language that you prefer, but you should have a set of, say, 10, 20 questions, which normally the patient needs to know. And that has to be very clear for you and the patient right up the front. You have instructions for the patient. The instructions are before the surgery, during the surgery, after the surgery. These have to be clear with you and your staff. When the patient comes, they are not shocked with lack of communication. Then you have the selection criteria. Would you buy an implant from X, Y, or Z, or do you have a protocol? Do you look for anything when you talk to the manufacturer, or do you even know who's the manufacturer? Is it only the salesman, or is it the price? Have you looked into the tolerance of the implant that you're using? And what's the precision? What's the animal and human studies that they have done? How many years have been they in the market? And so many other things. If they have FDA or they have CE, or what do they have? Are they supplying you with the lifetime warranty? Do they have a tracking information, lot number, batch number? And do they have a lot of commercially um, themes that actually do not mean anything but just to make you get impressed with the brand? Informed consent or consent form is a very important issue with implant dentistry today. How you want to set it up and how you want to make sure that somehow the maintenance and the recall is added to that. And what would the patient receive in terms of warranty from you? And what is the responsibility of the patient in terms of if the patient is, for example, continuing to smoke, if he's not taking care of his diabetic, his blood vitamin D level is dropping, and so forth. Emergency, what happens if the patient collapses? Who's the closest ambulance to your clinic? How many ambulances will it arrive? If something happens, what are you looking, what would you do? How accurate is your medical history taking during examination? What is the kind of a qualified staff you have in case something goes wrong? In an emergency situation, have you ever tried to go to the closest pharmacy and get a medication to make the patient not basically die? How do you take your x-rays? Are you trusting the calibration of your x-rays? What kind of a warranty you provide, and what kind of a malpractice insurance you have? I think those are the basic questions that you have, that when emergency comes, what would you do? The protocol that you running your clinic or your group practice, and when the patient comes for the first visit, what happens? How long does it take? What are the procedures? For example, if you are doing, we are running a program where panoramic x-ray is taken first, medical dental history, intraoral examination, bone sounding is done, then study models are taken, and then preoperative instructions are given, and photographs are taken. Now, this is our first visit protocol, which takes around 30 minutes. The second visit, which is the surgical protocol, we have a steps where we have certain protocol that we will do those steps during the surgery. For the prosthetic stage, we have certain protocol that can be shared with the patient, so the patient knows how many times they're supposed to come, and your staff and yourself are sure if something goes wrong, which part of your protocol you did not follow. Of course, it goes without saying, the maintenance recall protocol is the most important. Since I've been doing this since 1993, around 27 years of implant dentistry, I can tell you maintenance is definitely more important than what we mostly think. Also, it's good for you to understand the level of the case that comes to you. Is it in the anterior mandible? Is it in the maxilla? Is it in the posterior mandible? Is it in the anterior maxilla? And is it with the sinus? So if you understand how you classify these cases from the beginning, from the panoramic view itself, you know what kind of a case you deal with. You don't treat an implant cases anywhere in the mouth equally. If it needs a block graft, if it needs particulate graft, if it needs an open sinus lift, if it needs internal sinus lift, if it's an immediate extraction with immediate placement, if it's an extraction and you have to wait whether augmented or not, if it's with an autogenous tissue graft, or it's with a tissue graft from the fridge, or is it with the PRF? So all these things are important that you understand how complex is the case when they come to you. So a small classification for yourself, how you deal with different areas in the mouth, what equipments do you have, and what kind of armamentarium and supply you have in the fridge for different cases. Now we come to the center. Basically the 4 procedures that we do, as we mentioned earlier, is important because the more you do something exactly the same, the efficiency and the speed that you do will improve. For example, the 4 steps that we always suggest is panoramic X-ray intraoral examination, which includes the medical history and everything, photographs, bone sounding, and study models. And then you sit with the patient and explain the treatment plan. As simple as that. We also need to know how does the patient feel afterwards. So in our 5-year study, we basically took the data from different patients and we asked them, how do they feel? And based on that, we made a report, and now we tell the patient, by the way, because you are doing an internal sinus lift or you're doing an anterior ridge augmentation with 4 implants, on the first day you feel this, on the second day you feel that, on the third day you feel that. So the patient goes home knowing what to expect. Of course, it will not be exactly the same for all patients, but at least you have a clue when the patient calls on the 4th day saying, I have a huge swelling, I'm going to the hospital. You say, no, that's okay. Or if the patient calls on the same night and say, I have a swelling under my tongue, but I think it's okay, it's going to go away because you just did the surgery. You say, no, please go to the hospital. You might choke to death tonight because you perforated the lingual artery. So my point is, if you know what to expect, it's much easier. Also, the armamentarium is important for you to have a list of the armamentarium. You definitely need to know how you maintain the cleanliness, what's the protocol, whether it's a 1 minute or 2 minutes of brushing with chlorhexidine, what pre-medication the patient has to take. Do you scrub? You don't scrub? How long you think, to scrub? Do you wear a scrub suit or you just use your own gown? You cover your hair, your assistant, what do? Do they scrub? Do you have somebody as full-time as a person who will document the case, which takes the photographs and the radiographs during the procedure? Are you running a trio setup around the patient, or do you have another protocol? Do you keep track of the 40-minute window where we know if you can wrap up the surgery and suture it in 40 minutes, definitely the amount of swelling and post-operative discomfort is much lesser. Do you keep account of the temperature of the room? Something between 22 to 24 is ideal for us to be functioning at our best. Humidity below a certain level and above certain level kind of invites fungus in the area, or termite or ants or whatever things that you don't want. So keeping those 3 elements basically maintained at what you want is important. Now for the surgery, we have simple, straightforward surgeries where basically there's not much to be done. You place your guide or not guide, you open the area, you place your implant, whether you want to expand or not, you choose the system that you want, the size that you want, and you wrap it up and you suture it. But if you have an immediate extraction, then the story changes, but still it's a single implant. You're familiar with those. And for them, it's a straightforward procedure. Once you go to membranes and augmentation, of course, you need more experience, but still it's considered kind of a level 1 and complexity level. Once you go to the posterior mandible, of course, you need to have more experience, skills, and information, because sometimes, plus the inferior nerve, you have other elements to worry about. and you have to know more about the healing time versus because the hardness of the bone is slightly more than the maxillary area. So you basically have to be familiar with the speed of your drill and heating criteria, the 5-second rule that you cannot be inside the bone for more than 5 seconds, and so forth. So basically, if you do between level 1 and 2, you can even see that the duration of the procedure goes higher. And if you have a very thin ridge, then you go into piezo surgery and then expansion. And then, so the more you go deep into it, the more equipment, knowledge, skills, and experience you require to be able to handle those cases. That doesn't mean you cannot do simple cases all your life, or it doesn't mean that you can only take difficult. You can choose whatever you want. But if you choose to continue in this path, you need to always add knowledge, skills, and experience, because it's a never-ending specialty. If the extraction is involved, there are always 3 rules. One is either you extract it and place it right in the center, or you decide between one of the roots, whether it's the mesial or the distal. Here we chose the distal and we pushed it slightly mesial. Or in the third story is you just augment the area and come back later and place the implants wherever you please. So that is a decision making experience that you will gain as more cases you do. We also have a flapless protocol where once you are comfortable with the CBCT and reading of cross-sectional radiographs, you will be able to do cases without opening a flap. And it's very interesting if the case is straightforward and that you do not open a flap and you place the implant in the exact position where you want, you feel implant dentistry is such a simple procedure and all can be done very smoothly. And that part of implant dentistry is actually very enjoyable, amazingly enjoyable. And you can even proceed with today's digital world. You can even make your impression same day and even restore the case the same day with a temporary restoration out of occlusion, but still it's the same day. Once you go to the anterior maxilla, then things slightly take another route, because you have to worry about the smile design, you have to worry about the buccal bone, you have to worry about the Boozer's law with 2mm buccal bone is ideal, or is it a thick biotype or it's a thin biotype? Where will you place the augmentation area, where you will place the membrane, what kind of a membrane, how you'll make the incision, how you preserve the keratinized tissue. So once you're in the anterior zone, in our classification, you can Google, it's available online. You just type my name and those articles will pop up. We have at least 2 articles so far in classifying complexity. In our classification, anterior maxilla is level 4, which is one before the last level. So in that, you can, in the anterior maxilla, you have to be familiar either with procedures where you can take the impression during the surgery, either digital or manual. So you have a provisional restoration at the uncovery stage to shape the gingiva accordingly. This is the radiograph of the patient and how we managed to provide her with provisional restoration without preparing the natural teeth. And finally, the results were acceptable, even though the mesiodistal width of this area was much more, but playing with the ceramist architecture of the tooth, we would be able to manage anesthetic results, which was acceptable by the patient. So my point is, you should understand the complexity rate. and you should understand which one you are comfortable with and which one you're not. And as it can be very simple, implant dentistry, also it can be very complicated if you are not sure of where you're stepping into. For example, this is a straightforward case with an internal sinus lift, packing bone under the sinus. But if you perforate the sinus and all this material goes inside the sinus, as you can see here, we did the internal sinus lift. Then it becomes, the patient can be hospitalized and you need an ENT specialist to actually go and remove all the graft that you placed in the sinus. Not only the cost of the patient goes higher, also the trust that you've created will be highly diminished. So that's why we are emphasizing on the complexity of the case and for you to be able to manage the complexity. I'm not going to go to block graft and lateral window and so forth, just because the time, but my emphasis in for you to understand the complexity of each case. The experience after implant surgery, as I mentioned, if you have a good data on a daily communication with your patient, within 1 year, you will have a very nice document where you can provide to your patient what should they expect after the surgery. And that's very realistic. And you can relate that to the complexity index. Regarding uncovery and impression, it can be mixed sometimes in one visit. It's a straightforward, if it's a simple procedure, you just make impression with even an abutment or implant carrier from any system you want. And it can be open tray or even closed tray. It depends how accurate you are. And you can manage the soft tissue in a way that you don't punch or lose it. And eventually, it will take the shape of your ceramic crown if it's done right. Once you go to a more complex area, then you deal with multiple cases where more than one implant is involved. Of course, you need to understand the mobility of the impression material while it sets, I mean the shrinkage, and the expansion of the stone while it sets. So connecting things together will definitely, on a bridge, will give you better results versus just leaving them alone and look at each implant individually. If you're not connecting them as a bridge, then you probably do not need to connect them in the mouth while taking the impression. For multiple cases, things will change, of course, because then you have to deal with so many other elements. Occlusion, whether you are into canine protective occlusion or group function, then basically the knowledge of occlusion plays a role, and you have to understand the concept of occlusion when it comes to this level. With overdentures, whether you're using a ball and socket or different methodologies, what we have found is the overdenture, if you can find a methodology where minimum patient's visit is provided, is definitely better for the patient and yourself. And the patient is not always trying to come to you to change a plastic part. So we have found telescopic abutments, which is milled by the lab. So it's a custom-made abutment, basically, is the longest lasting overdenture procedure. So nowadays, we try to stay away from all those ball and socket and zag and different prostheses. Quality control between you and the lab, I think it's tremendously important. The top case and the bottom case, when you look at it on your table, especially without magnifying glasses, they are not very different. But once you look into it with a more magnification, you will find a tremendous amount of error where the labs, the way they treat our abutments. So this, by naked eye, looks very much like the lower one. But when you keep looking at the quality of a lab that uses a microscope and the way it fits without any gap in the margin, and when the ceramic comes and fits, it's amazingly tight. And with the other type, you can see how much of a gap is present. Now, with naked eye, you cannot see that. But the calculus formation on the crown or on the abutment, which is exposed, definitely can prove to you that you need to either change the lab, use a microscope, or at least have a quality control of the things that come from your laboratory. So it's very important for you to have a quality control on the prosthesis that you receive, because all of these cases have been sent to qualified dental labs. But once we look at them under a microscope, we are not happy with the results. With the naked eye, they are very nice, but with the microscope, you can see that the ceramic has been boiled. The temperature is raised. Some areas are not covered with a smooth ceramic, which is an area for calculus. And definitely, this is not going to be a smooth surface for the food to just slide away. So there is a difference. Always there is a difference between the labs who use a microscope and a lab that uses only hands and eyes. And also the analogs that you keep sending back, maybe if you look into it by a magnification, you will see that it's not the same as the implant. So you basically, your crown in the lab, because you send them such an analog, does not fit the same way that it will fit in the mouth. I don't know how many of you take radiographs of your models, and I don't suggest you start taking them. But if you do, you will see that there is a gap between your old analogs and the abutment. And that shows that there is no really reason to keep reusing your analogs. So my suggestion is the analog should be used once, and the model can be kept for the same patient for the future reference. And these gaps cannot be seen by naked eye when it comes from the lab. So you're missing on the fitting of your crowns. And now you might say it's a single crown, it doesn't matter, but when it becomes a bridge and there is peri-implantitis and we blame the patient for smoking, maybe it's not only the patient that we should blame, also the quality of our prosthesis. Then we go to the maintenance. In the maintenance world, I think at the time of surgery, the patient should know why this maintenance is important. And for us, there are 4 elements that we, actually there are 5 elements, but 4 of them is done every year, and the 5th one is only done every 5 years. The 4 elements are, we will evaluate the calculus. It's 1+ or 2+ or 3+ when we see the patient every year. And we sit with the patient and say that if he's or she is 3+ or 2+, we don't wait for the next year. We ask them to come more frequently. The second element is the bone level. So we take a radiograph every year and compare the bone level with the last year. The third one is probing on bleeding on probing. So we have a special probe where we check if the patient bleeds around the implants or not, and then that opens a flag in our head that this patient needs more time to see why there is inflammation around the implants. And the fourth one is occlusion and contact, and the contact with the implant and the neighboring teeth, if it has changed from the last 1 year. The fifth one, which we do every 5 years, is the torque control. We want to make sure that the patient has all the screws are tight and not loose. In case we find things are in control, we call them class 1 or 2. The 3 takes a different level, and the 4th and the 5th is basically removing the implant and either doing nothing or replacing it with another implant. So we have a protocol for maintenance where we really have pride in applying it. Case reports, we have a format which is easily can be copy and paste, so we don't spend too much time when the patient asks for a case report. Same thing as PowerPoint presentation. We can present that case to anyone, anytime. Skills is our inquiry skills, which I might get into it in a more deeper way if there is time. Research is, we try to publish 1 article a year, and we are doing fine with that. Sometimes it gets 2 articles in 1 year and sometimes none, but as an average, I think it's good to share with others what you do. I think you should keep up with the manufacturers because new ideas produce new concepts, and it makes their implants in a better way. So I think it's good to know what is coming to the market. A data bank or logbook is a necessity part of your practice. I think you should have a logbook. It's a little detailed, the one which we make, because we need to know so many things about this single implant. So every implant has pretty much all the information we need for the future if something goes wrong. The lab name, the superstructure, if it fails, why it failed, the radiograph at the time of surgery, who placed the implant, who restored the implant, when was it uncovered, what surface, what was the torque, what was the thickness of the soft tissue and the hard tissue around the implant, and so forth. So basically, I think a logbook is definitely necessary. CME, to me, is the core of making sure you are up to date, because implant dentistry definitely is evolving and it's improving very fast. So if you're not connected to somewhere which you can be updated by attending physically and practically, I mean clinically, and reading the literature, I don't think you'll be up to date. So basically, the pyramid that I'm discussing is this. It has, okay, it has those 3 components: the top part, the middle part, and the bottom part. The bottom is the infrastructure, which is necessity for this building not to be destroyed. Now, about the middle part, I will just repeat this. If you can imagine the middle part as a 7-story building, where every building, every story in the building has its own rooms and its own importance. This is easier for you to understand. And in every room, for example, in the surgery floor, one of the rooms is incision room. In the incision room, you will basically have good experience, skills, and knowledge how to make an incision, what blade to use, and how to hold the blade that you're making the incision. When it touches the bone, how should it feel in the incision, and so forth. So in the surgery floor, you basically have to improve your experience, skills, and knowledge in all the elements of that room, which is the step in performing a surgery. Of course, all the steps, you should know what you're doing before you do it. You just can't do an uncovery or an impression and not knowing the steps in detail. My point is, once you know the steps, I think you should write it down and you should improve on each one and make sure that you have improved your skills, knowledge, and experience on each one separately. And don't look at it as the same as extraction. Surgery is an extraction, placing an implant is a surgery, so placing an implant is just like extraction. No, it's not. The steps which is required for everything in implant dentistry requires more skills, experience, and knowledge, which is not being taught to us in the undergraduate the way we were taught how to do a filling or a root canal. So you have to do that on your own. For example, I mentioned this earlier, if a patient comes to you with calls you after the surgery and she has a swelling, if you know what kind of surgery you've done, then you can always tell the patient, this is the second day and I expect that. But if this happens after the restoration, then you know that it was due to infection, and then you have to give the patient a different treatment. So for you to know, or if something broke, for example, you should know the steps of every procedure, and accordingly, you should decide what to do. If your bone graft is exposed after the surgery for 1 day or after the surgery for 1 year, there is a big difference in terms of what you will do with it. So if you don't know your steps of every procedure, then you will not know how to manage your complications. And when it comes to surgery, as I mentioned, maybe you will be dealing with implant placement and crown in the beginning, but slowly you will go to block grafting, to open sinus lift, immediate extraction, and the list keeps going further and further. I will just try to go to the principles and applications of how to teach implant dentistry today very quickly. I think it should be done in levels, and we have started this in year 2000. We have so many doctors from all over the world who have come and mentors from different parts of the world, and we train doctors in all different levels, which is all the augmentation procedures as well as the soft tissue and hard tissue. We go through the literature, we classify the case, and we try to publish an article as a team every year, so we can have production after sharing the things that we learn to others. And as the time is 40 minutes, I don't want to continue more because of the lack of time. But my point is, the key for learning how to educate others doesn't end with just knowledge. You need to mix experience and skills, and you have to have it as a protocol-based method by which you can accordingly receive the expertise to be able to practice implant dentistry. Thank you.
All right, perfect. Let's start with the question and answer session. Can you please share the clinical protocols and patient consent forms? How do we go about it?
The informed consent basically has 3 components. One is we tell them frankly that if you do the surgery with us for 5 years, we'll take care of all discomforts that you have. Why? Because we know for 5 years actually nothing can go wrong because of the quality control that we have. So we give them that comfort in the beginning. The second part is we basically tell them that you have to follow our instructions. Otherwise, this informed consent will not be active. And the third part, we tell them what we will do every year if you come for a maintenance visit, which I told you it's 5 steps, and that's it. So that is the 3 components in the informed consent.
Thank you, doctor. We move to the next question. Why is the internal hex less preferred over conical hex? What is the difference between internal hex and the conical hex connections?
I'll tell you the story because I told you I started this in 1993 where everything was external hex. Then Gerald Nisnik came along and he inverted the external to the internal. And of course, it was much better idea. So we followed that invention and we switched to internal hex. Now, with the first internal hex from, first external hex from Brannemark, it was 0.75 millimeter. And then BioHorizon came along and they made it 1 millimeter. And then when they did the internal hex, the same depth was inverted, so the doctor can feel the fall of the abutment internally. So when there is an internal hex, okay, the contact point of the abutment and the implant is basically around 1 millimeter. Now, that contact point, okay, because of the movement of the abutment, there will be a leakage of liquid between the implant and the abutment as you chew on the restoration. So that was not a good thing. Why? Because the bone resorption around the neck of the implant was contributed to this issue. So one idea from Boozer was to make one-piece implant. And they thought it's going to be successful, but it was not. The one-piece implant is the abutment and the implant is one piece. So there is no way that as you eat, there is a pumping of liquid in the implant and out. That led to what? The invention of the internal cone. The cone is a longer surface than a hex. So the cone actually, the reason why it was invented was so there is a longer distance between the abutment and the implant, by which stops the bacteria from going in the implant and out every time the patient is chewing. Now, Morris, 100 years ago, he's an engineer, and he said, if you can make a taper between 3 to 7 degrees, there'll be such a locking mechanism or cold welding mechanism between two metal surfaces that basically it will not move and doesn't allow the bacteria to penetrate. However, 3 to 7 degrees in practicality is not possible. Why? Because every time you want to remove the abutment, the amount of force you apply, the patient will be very irritated. So they came up with the 10 degrees. They still call it Morris taper, even though Morris died and he would not accept because his theory was 3 to 7, but around 10-degree taper, where two metals are in contact, this will reduce the influx of bacteria in and out. It has its own drawbacks, which is again the easiness of removing it and putting back. Some companies have come with a screwdriver that you put it in the abutment. As you rotate it, the abutment pulls up, but sometimes the screw is already there and you can't get it out because the restoration was built in a way that the screw cannot be removed. So that device is not going to work, and you have to hold the head of the patient and using an artery forceps, pulling this abutment out, which is very, very frustrating, but it definitely reduces the amount of bacteria flux in and out between the abutment and the implant. Next question.
Thank you, sir. Last two questions before we wind up the session. So recently I had heard a lecture wherein the speaker said that probing around the implant is not recommended nowadays as it would create unnecessary trauma. What is your recommendation about this? Is there any protocol that you follow?
Of course, you have to, I'm not saying use your force to cause trauma. You should buy the right instrument where the tip is rounded and it's marked, and you have to use the correct pressure, and you have to detect perimucositis before it goes to advanced level and becomes periimplantitis. It's your duty, it's your job, it's your responsibility to do this at least once a year. It's not an option that you heard in a lecture, that somebody said something. That is not professionally acceptable. Your job is to at least make the patient aware that peri-implantitis, if it comes, sometimes it's not treatable. So for you to avoid the patient getting to that stage, you have to detect it at early stage. And the only way to detect it is using a probe, the correct probe with the correct pressure, okay, and detect if there is a bleeding. Then you do a refractory protocol. You can look into the articles from Toronto by Dr. Goldberg, and you can follow that.
Thank you so much, sir. Next question. Sir, how do we avoid any nerve injury during osteotomy?
When you mean any, you mean basically inferior alveolar. I don't know what other nerve injuries you're talking about. You either talking about the mental exit, mental foramen exit, or the inferior alveolar nerve. Basically, you should. It's good to use a stopper drills when you're dealing. We call it complexity index. We call it level 3. Posterior mandible to us is level 3. In level 3 cases, we always use a stopper at the drills. That's one. Second thing, we study, we go 5 millimeter with the first pilot drill, take a periapical x-ray, recalculate the position of the nerve in relation to the implant that we're planning to place. And we have a support with our hand, so our hand will not slip. This becomes more critical in the immediate extraction cases because there's no bone and it's very easy for your hand to drop and you damage the nerve.
Thank you so much, sir. I think this should be the last question. The whole world is now talking about immediate loading implants and fixing teeth in 3 days. If that is the successful scenario, then why are people still practicing conventional implantology?
Because it's not for all. You cannot apply any law. Take going to school. Going to a school is a general law that almost, if I remember correctly, maybe 450 years before Christ, Plato and Socrates have invented schools. Until today, people go to schools. And it's an acceptable phenomena that we should go to schools. But not everybody goes to schools, even though it's much more, we have more than 2,000 years of, 2,400 years of data on people who go to schools definitely are doing better than people who don't go to schools. But I know a lot of people, for many reasons, that they just can't go to a school. So any law, even going to school, which is a very known law, believing in God is a known law, but many people don't believe in it. So any law, no matter what the law is, it cannot be 100% applicable to all. So immediate loading is a law or a concept that is definitely applicable for many people, and it's definitely, like any other law, not applicable for all human beings in the world.